Welcome back to the deep dive. Today, we're scrapping the usual format. No broad overviews, no, casual skimming. We are simulating a pressure cooker.
You certainly are.
We are going right into the operating theater or maybe more to the point, the examination hall.
That's exactly right. And look, I'm not just the expert today. I want you to think of me as your external examiner. I'm the senior faculty member from a neighboring medical college. I'm sitting across the table from you. And frankly, I've heard every wrong answer in the book.
Okay.
I have zero patience for fluff. My job today is to grill you, yes, but ultimately it's to get you to pass.
Yeah.
Because this topic we're covering, it isn't just for marks.
Yeah.
It's the difference between a patient going home and a patient not.
I'm ready. I'm no longer the host. I'm the, let's say, the terrified postgraduate student preparing for the Gujarat University anesthesiology exams. I've got my Miller, my Guyton, and my Stolting stacked right here.
Good. The topic is reflexes relevant to anesthesia practice. And specifically, we're talking about the ones that kill. The Bezold-Jarisch reflex is the main event, but we'll hit the oculocardiac, the Cushing, all of them. This is high-stakes physiology. So, doctors, setup's great. Let's begin. Part A, introduction and exam framing.
Understood. Let's do it.
All right. Don't give me a dictionary definition. In the context of our practice anesthesia, what is a physiological reflex?
Okay, so a physiological reflex is, well, it's basically an autonomic stimulus response loop. It's the body's hardwired attempt to maintain homeostasis.
A loop, okay.
Yeah, and for the exam, I know I need to be able to identify the four key components.
Not sure.
A sensor or receptor that detects a change, then an afferent pathway that carries the signal to the CNS, a central integrator, which is usually the brainstem or medulla, and then finally the efferent pathway that triggers an effector organ.
Fine. That's first-year physiology.
Yeah.
Now, tell me why I, as a senior anesthetist, actually care about this. Why is this a question that comes up again and again in the MD exams?
Because anesthesia is really the art of manipulating these reflexes. We're either blunting them with our jugs or sometimes we accidentally trigger them.
And when we do.
It's a disaster. These reflexes aren't just textbook trivia. They're the primary cause of that sudden, unexplained intraoperative hemodynamic collapse.
Exactly. The, oh my God, what's happening moment.
Yes, you can be cruising along in a totally stable case, everything's perfect, and then boom, a systole on the table.
Exactly. Now, in the Gujarat University exams and others, you're going to see this in three places. First, the theory paper. Write a short note on the Bezold-Jarisch reflex. That's a classic 5 or 10 mark question.
Right, standard.
Second, the OSCE station. You might get a clinical scenario, a patient crashing during eye surgery or maybe a shoulder arthroscopy. But the third place, that's the most dangerous.
The viva voce.
The viva. The oral interrogation.
Right.
I'll be sitting there and I'll ask you, doctor, why did the heart rate drop? And if you just say hypotension, you fail. It's an instant fail.
Because it's not specific enough.
Not even close. I'm looking for specific keywords. I want to hear about the fibers, the nuclei, the paradox. So with that in mind, let's dive into the big one, Part B, the Bezold-Jarisch reflex.
The BJR, the exam core, as you'd say.
Absolutely. So define it for me. I'm the examiner. I'm looking at my watch. Go.
The Bezold-Jarisch reflex is a cardio-inhibitory reflex. The gold standard definition, the one from Miller's Anesthesia, is a triad. You see three things happen at once.
Name them.
Hypotension, bradycardia, and coronary artery dilatation.
Stop right there. You said coronary artery dilatation. Why did you include that?
Right.
Most students, they forget that last one. They just say hypotension and bradycardia.
Because that part, that's the key to the whole cardioprotective theory. It's what distinguishes the BJR from just a simple, vasovagal collapse. The dilation suggests the body is actively trying to perfuse the myocardium, even while it's slowing everything else down.
Good. You've read the big books. I can tell. Now, give me the historical context just briefly. Examiners love it when you can drop a name or two.
Okay. It was first described, I think, by von Bezold and Hurt back in the 1860s, and then later clarified by Jarisch. But really, the key concept for the exam isn't the history, it's paradoxical nature.
Explain that. Why is it paradoxical? This is the aha, man. This is the whole point.
It's paradoxical because it completely contradicts the baroreceptor reflex. I mean, normally, if your blood pressure drops, the baroreceptors in the carotid sinus and the aorta, They scream, low pressure, and the heart rate shoots up. You get tachycardia to try and restore cardiac output. That's the normal logical defense.
Right. Your body hits the gas pedal.
Exactly. But with the BJR, the patient is hypotensive, but instead of speeding up, the heart slams on the brakes. The rate plummets. You get a profound bradycardia right in the face of hypotension. It fundamentally works against the body's immediate attempt to maintain its own perfusion pressure.
Precisely. It's a reflex that seems, on the surface, to be sabotaging this systemic circulation.
Yeah.
It makes no sense, which is why you need to understand the mechanism. So let's get granular. Section 3. Receptors and pathway. Where are the sensors? And don't just say the heart.
Okay, specifically, they are mechanoreceptors and chemoreceptors located within the left ventricular wall.
Be more specific. Which part of the wall?
Primarily the infraposterior wall of the left ventricle.
Correct. Now, how does the signal get from that spot in the ventricle up to the brain? This is the specific phrase I have on my checklist. I'm waiting for it.
The signal travels via the vagus nerve, but specifically, it's carried along unmyelinated vagal afferent type C fibers.
Boom. There it is. Unmyelinated C fibers. If you say those 3 words in the Viva, I can tick a box. I know you understand the physiology. Why does it matter that they're unmyelinated?
Well, unmyelinated fibers usually imply a slower, more visceral type of transmission. It's not like sharp pain or somatic sensation. It's a deep distress signal.
Correct. So this distress signal travels up the C fibers to the nucleus tractus solitarius, the NTS in the medulla. And then what happens?
The NTS gets that signal and it triggers a massive autonomic shift. It cranks up the parasympathetic tone, so the vagus nerve just hammers the SA node, which causes the bradycardia.
Right.
And at the exact same time, it causes a complete withdrawal of sympathetic tone from the blood vessels.
It causes
massive peripheral vasodilation. The vessels all go floppy, blood pools in the periphery. So you end up with this slow heart trying to pump into a completely dilated, boggy system. That's why the pressure crashes so profoundly.
And the coronary dilation you mentioned earlier.
That's part of the same process, a mix of sympathetic withdrawal and some direct vagal effects right on the coronary bed itself.
Okay, you've nailed the mechanism. But the bigger question is why? Evolution usually doesn't design suicide switches. Miller talks about a theory for the purpose of this reflex. Why would the body want to shut the heart down when the pressure is already dangerously low?
It's that hemorrhagic hibernation idea, or the cardioprotective theory. The logic is that if the heart is either ischemic or running on empty, beating faster is actually the most dangerous thing it can do.
Go on.
Tachycardia just consumes a massive amount of oxygen. If you're running on fumes, sprinting is what's going to kill the engine for good.
Exactly. So the BJR.
The BJR acts like a circuit breaker. It senses that extreme stress, the ischemia or the violent squeezing of an empty chamber, and it forces the heart to slow down. It's basically screaming, stop, conserve energy, dilate the coronaries, and just try to survive this insult.
So it sacrifices the system to save the organ.
Precisely. It sacrifices the systemic blood pressure to save the heart muscle itself. A desperate last-ditch effort.
Brilliant description. It sacrifices the organism to save the organ. You might also see apnea mentioned in some textbooks, usually in animal models, but let's be clear. In clinical practice, it's the hemodynamic collapse that kills the patient.
Right. Our focus is always on the circulation.
Now, let's move to the most important part for us. Section 5. Triggers and clinical scenarios. This is where you earn your MD. I don't care about rats in the lab. I care about the patient on my operating table. When do we actually see this reflex?
Okay, the interscalene block. Miller and Morgan are just full of warnings about this one. Specifically, when the surgery is done in the beach chair or sitting position.
Walk me through it, step by step. Why does a numb shoulder lead to a cardiac arrest?
It's the perfect storm. First, you put the patient in a sitting position. Gravity immediately pulls blood down into the legs. You get venous pooling, so venous return to the heart starts to drop. So the left ventricle becomes underfilled. At the same time, the patient is usually awake or just lightly sedated. They might be anxious, so they have a high background sympathetic tone. Adrenaline is flowing. The heart is being told to beat hard and fast.
But the chamber is empty.
Exactly. It's hypercontractility against an empty chamber. The ventricular walls are literally squeezing and rubbing against each other. The mechanoreceptors embedded in the wall get crushed and squeezed.
And they misinterpret that signal.
Completely. They sense this violent squeezing and they think, wow, the pressure in here must be astronomical, even though the volume is critically low.
So they fire the C fibers.
They fire the afferent loop. The brain gets a false signal that the blood pressure is dangerously high. So what does it do? It triggers the BJR to lower the pressure.
And the result?
Massive vagal outflow. The heart rate drops to 30, then 20, then a systole. Lights out.
And that, right there, is the empty heart theory. The mechanoreceptors are tricked by the empty squeeze. Now, this brings us to the absolute favorite topic of the Gujarat University examiners. It's a guaranteed question. BJR in spinal anesthesia.
Yes, this is the big trap. I know this one.
It's a trap because it looks exactly like something else. So I'll give you the scenario. You're the resident on call. You give a spinal for a hip fracture. The level comes up to T6. It's a perfect block. Hemodynamics are rock solid. You relax. You start filling out the chart. 20 minutes later, not immediately, but 20 minutes later, the monitor alarms. Heart rate 40, blood pressure 60/30. What happened?
The knee-jerk answer, the wrong answer, is high spinal.
And why is that the wrong answer?
Because a true high spinal, where you've actually blocked the cardioaccelerator fibers at T1 to T4, that usually happens early as the block is setting up. And the mechanism there is just a passive loss of sympathetic push. The heart slows down because its gas pedal has been cut off.
Correct.
Yeah.
But in our scenario, it happened 20 minutes later. The key is the delay.
That's the signature of the BJR. The spinal anesthetic caused profound vasodilation in the legs and the abdomen. Over those 20 minutes, blood just slowly pooled. The central blood volume dropped and dropped. The ventricle got emptier and emptier until eventually it crossed a critical threshold.
The empty heart threshold.
Yes. The mechanoreceptors fired and the vagus nerve attacked the heart.
The vagus nerve attacked. I like that phrasing. It implies an active, aggressive process. In a high spinal, the sympathetic system is simply asleep. In the BJR, the parasympathetic system is wide awake and aggressive. That is the core distinction you must make to pass the VIVA.
So if the examiner asks, is the bradycardia in spinal anesthesia only due to a sympathetic block? The answer is a hard no. It's a combination. And in a delayed arrest, it is almost certainly the BJR.
Exactly. Now you've diagnosed it. Section 7, management. You're the anesthetist in the room. The patient is crashing. What do? Don't give me a long list. Give me protocol.
Okay. Identify and act. First, I know this isn't just simple hypotension. This is a collapse. So, step 1, restore preload. Immediately. Get their legs up. If they're in a beach chair, you dump the bed flat as fast as you can. I have to fill that empty heart to stop the mechanoreceptors from firing. That's the root cause.
Good. What's next?
Step 2, fluids. Open the IV wide. You have to treat the volume deficit that started this whole cascade.
Okay, and drugs.
Drugs, yes. Atropine or glycopyrrolate. I need to block that efferent vagal limb. That's what's going to deal with the bradycardia.
But the heart rate is 30. The BP is 50 systolic. Atropine isn't working fast enough. Yeah. What is the drug of choice, according to Stolting, in a severe collapse?
In a severe collapse, it's epinephrine, adrenaline.
Why not ephedrine? We use ephedrine for spinal hypotension all the time.
Because ephedrine is an indirect acting agent. It works by making your own nerve endings release norepinephrine. But in a severe BJR or a high spinal, the sympathetic system is already completely shut down or exhausted. There's no norepinephrine left to squeeze out.
So it's useless.
Right. You need a direct agonist. Epinephrine hits the alpha and beta receptors directly. It completely bypasses the dysfunctional nerve ending.
Correct. Do not tickle the patient with ephedrine if they are dying. You give small, repeated boluses of epinephrine. It restores the vascular tone, and it directly kicks the heart rate up. And what about prevention?
Prevention is everything.
So?
Co-loading. You have to be aggressive with hydration before or during the block. The key is to never let the heart get empty in the first place, and be incredibly careful with sitting positions, especially in patients who might be dehydrated.
Very good. You've passed the BJR station, the triad, the C fibers, the paradox, and the management. But the exam isn't over. Let's move to part C, other important reflexes. We can't ignore them. Let's start with the I, the oculocardiac reflex. OCR.
Ah, the 5 and dime reflex.
And why do we call it that?
It's just a mnemonic for the cranial nerves that are involved.
Yeah.
The afferent limb is the trigeminal nerve. That's cranial nerve 5, V. And the efferent limb is the vagus nerve, cranial nerve 10, X, 5 and dime.
It's a cute mnemonic, but I'm an examiner who likes details. Trace the path for me.
Okay. The stimulus is traction on the extraocular muscles. The books say the medial rectus is the most potent trigger, or direct pressure on the globe, like during a retrobulbar block or from trauma.
And the signal goes where?
The signal travels down the ophthalmic division of the trigeminal nerve to the Gasserian ganglion.
Keep going. Where does it connect in the brainstem?
From there, it goes to the main sensory nucleus of the trigeminal nerve, which is in the floor of the fourth ventricle. Yao and Artuzio is very specific about that point. Then it jumps across through interneurons to the vagal motor nucleus.
And the result of all that wiring?
Immediate, profound bradycardia. Or worse, you can see AV block, ventricular ectopi, or it can go straight to a systole. It's like a light switch.
Yeah.
The surgeon pulls the muscle, the heart stops, they let go, it starts again.
Which brings us to management. What is the very first thing you say in that situation?
Stop, I tell the surgeon, stop traction, let go of the muscle. That is the single most effective treatment. 9 times out of 10, the rhythm returns immediately.
And if it keeps happening every time they pull?
Then I need to reassess my anesthetic. First, I check my depth. Light anesthesia makes this reflex much worse. Then I check for hypoxia and hypercarbia. Both of those things will sensitize the heart to this vagal reflex.
Good.
And if everything is perfect, deep anesthetic, good ventilation, and it's still happening, then I'll give a dose of atropine prophylactically.
Good. Now, why do we see this so much more in kids? Strabismus surgery is a classic pediatric case.
Because kids are vagatonic, their resting parasympathetic tone is just much higher than in adults, and they really rely on their heart rate for their cardiac output. So for them, a sudden drop in rate is hemodynamically devastating.
Very true. Now, briefly, what about the variants mentioned in Section 9? Oculopulmonary, oculogastric.
Right, it's the same trigger traction on the eye muscles. But the vagal output, instead of just going to the heart, also goes to the lungs, causing bronchoconstriction, or to the stomach, causing hypermotility and nausea.
And the clinical relevance of that.
It helps explain why these kids often wake up vomiting after strabismus surgery. It's not just the opioids or the anesthetic, it's the reflex itself kicking the stomach and making them feel sick.
Excellent point. That's a distinction-level insight. Now, let's move down the anatomy, the airway, the laryngocardiac reflex.
This is our bread and butter. This is laryngoscopy and intubation.
What's the pathway?
The afferent is the vagus, or the glossopharyngeal nerve, from direct irritation of the larynx or the trachea. The efferent, again, is the vagus.
And the result?
Bradycardia and hypotension. Again, Miller really emphasizes this is a pediatric issue. In adults, we usually see the opposite, right? We see a huge sympathetic surge from the pain of intubation. We get tachycardia and hypertension.
But in a baby?
But in a neonate, if you're too aggressive with the laryngoscope blade, they will Brady down on you in a second.
Which is why we used to pre-medicate all children with atropine before induction. We don't do it routinely anymore, but that knowledge is always in the back of our minds. What is the absolute #1 rule for pediatric bradycardia?
Hypoxia until proven otherwise.
See again.
If a child has bradycardia, it is hypoxia, period. It's not the reflex, it's not the drug, it's lack of oxygen. Check the tube position, check the circuit, check their color. Only after you have definitively ruled out hypoxia can you start blaming a reflex.
Yeah, never, ever forget that. Now, let's move to the neck, the carotid sinus reflex.
Okay, this is a pure baroreceptor reflex.
Where are the sensors?
They're in the carotid sinus, which is a little bulge right at the bifurcation of the internal carotid artery. They're stretch receptors.
In the afferent nerve.
It's Hering's nerve, which is a branch of the glossopharyngeal cranial nerve IX.
Good name drop. Hering's nerve. And the response it generates?
Well, its job is to regulate blood pressure second by second. If the systemic pressure is high, the sinus stretches. Hering's nerve fires. The brain then inhibits the vasoconstrictor center and excites the vagal center. The result is vasodilation and bradycardia to bring the pressure back down.
And the clinical relevance for us?
Neck surgery, especially carotid endarterectomy. If the surgeon is dissecting around that carotid bifurcation, they can put pressure on the sinus and trick it into thinking the pressure is 2,100.
And boom.
Boom, sudden profound hypotension and bradycardia. Also, Miller makes a point that our volatile anesthetics, like isoflurane, actually depress this reflex. So under general anesthesia, patients can't compensate for blood pressure swings as well as they can when they're awake.
Correct. Okay, now let's go inside the skull. The Cushing reflex. This one is the grim reaper of reflexes.
Yeah, this is a sign of impending doom. It's the body's last-ditch physiological response to dangerously high intracranial pressure.
Give me the triad, the Cushing triad.
Hypertension, bradycardia, and irregular respiration.
Walk me through the mechanism. Why on earth does the blood pressure skyrocket?
Okay, so you have a bleed or a tumor or swelling inside the skull. The ICP starts to rise. Eventually, the pressure inside the skull gets higher than the mean arterial pressure. The blood vessels inside the brain get squashed flat.
So blood can't get in.
Exactly. The brain starts to suffocate cerebral ischemia. The brainstem is starving for oxygen.
And the brain panics.
It absolutely panics. It activates what Guyton calls the CNS ischemic response. It initiates a massive, overwhelming sympathetic outflow to the entire body. It clamps down on every peripheral blood vessel it can find.
Right.
It's trying to force the systemic blood pressure up to make it higher than the intracranial pressure. It's a brute force attempt to restore its own blood flow. That's what causes the severe hypertension.
Okay, that explains the hypertension, but why the bradycardia?
Because the baroreceptors in the aorta and the carotid are still sitting there doing their job. They see the systemic blood pressure hit 220/120, and they scream, way too high! And they try to lower it by slowing the heart down via the vagus nerve.
So you get this physiological war.
Exactly. The brain is desperately trying to drive the pressure up to save itself, and the body's baroreceptors are desperately trying to bring it down to save the system. The bradycardia is the result of that conflict.
A terrible, futile war. If you see this triad in a head trauma patient in the ER, what does it mean?
It means herniation is imminent, the brainstem is being crushed. You need to hyperventilate them, give them mannitol, call the neurosurgeon, and get them to drill a hole immediately.
It is a true neurosurgical emergency. Okay, one last quick one. The vagovagal reflex.
This one's simple, vagus in, vagus out. Usually peritoneal stretching. The classic example is the insufflation of gas during laparoscopy. The surgeon inflates the abdomen, the peritoneum gets stretched, that sends a signal up the vagus, and the heart slows down.
Simple enough. Now, doctor, we're moving into Part D, comparison and integration. This is where I separate the past students from the gold medalists. I want you to visualize a table in your mind.
Okay, I'm visualizing it.
Column 1 is the stimulus. Column 2 is the response. I want you to compare 3 reflexes for me. BJR, the baroreceptor reflex, and the Bainbridge reflex.
The Bainbridge reflex. Okay, that's the tricky one.
It is. Define it first. We haven't touched on it yet.
The Bainbridge reflex is essentially the reverse of the BJR. It's triggered not by low volume, but by high volume. It's the stretch receptors in the atria that sense that the heart is being overfilled.
And what's the response to that overfilling?
Tachycardia.
Yeah.
The heart speeds up to try and pump that extra fluid forward. It's a mechanism to prevent blood from damming up in the venous system.
Good. So let's build that table. Bezold-Jarisch reflex. Stimulus is low volume, the empty heart. Response is bradycardia. Now, Bainbridge reflex, stimulus.
High volume and overfilled heart.
Response.
Tachycardia.
Good. Now, baroreceptor reflex, stimulus is what?
Stimulus is a change in pressure, not volume. So let's say low pressure.
And the response to low pressure.
Tachycardia.
Excellent. Now, synthesize that for me. This is where it gets really interesting. Let's say I start to hemorrhage. I have low volume and low pressure. Which reflex wins?
This is the cool part. Initially, as you bleed, the baroreceptor reflex wins. The drop in pressure causes a compensatory tachycardia. That's what we see first.
Right.
But if the hemorrhage is severe enough, if the volume loss becomes so critical that the ventricle starts to run empty, then the BJR takes over. It overrides the baroreceptor reflex and the heart rate suddenly crashes. That's the terminal event.
Brilliant synthesis. They're opposing forces, and the BJR is the last desperate one to fire. Now, a final Viva question for this section. A structured answer, please. Doctor, you're in the OR. Your patient's heart rate is 40. List the differential diagnosis. Don't just ramble. Give me categories.
Okay. I would use the examiner safe structure. My categories would be...
Go on.
1. Reflex mediated. Is the surgeon pulling on the eye, OCR? Is the abdomen being insufflated, Vagal? Or is the heart empty from bleeding or venous bowling, BJR?
Good. Category 2.
2. Drug-induced. Did I just give a big bolus of fentanyl or remifentanil? Did I give a high dose of dexmedetomidine? Did I repeat a dose of succinylcholine, especially in a child?
Excellent. Category 3.
3. Physiological. And at the top of this list always is hypoxia, especially in a child. Then a high spinal blocking T1, T4.
And the last one.
4. Surgical. Is the surgeon physically manipulating or compressing the vagus nerve in the neck or chest? Direct stimulation.
That is a rock-solid, safe, and comprehensive answer. It covers the common and the deadly. Now, Part E, final exam integration. Let's quickly review the common Viva traps. Trap number 1. I ask you, why did the patient arrest after the spinal was working perfectly for 20 minutes?
The answer is, it's the BJR, triggered by progressive venous pooling leading to the empty heart state. The delay is the clue.
Perfect. Trap number 2. Is the bradycardia seen in spinal anesthesia only due to the sympathetic blockade?
Answer, no. It is a combination of the direct sympathetic block at T1, T4 if the spinal is high, and D, the active reflex vagal activity from the BJR if venous return is poor.
Exactly. Trap number 3, a more subtle one. How does the Valsalva maneuver relate to all this?
Miller mentions this. A sustained Valsalva maneuver increases intrathoracic pressure, which dramatically decreases venous return, so it can mimic the empty heart physiology and trigger similar baroreceptor and BJR-like changes.
Very good. You're anticipating the curveballs. Now, section 17, diagrams. You have 10 minutes left in your theory paper. You need to draw the BJR pathway. What do you put on the paper?
Okay, simple is best. I draw a heart. I label the left ventricle and write Mechanoreceptor Chemoreceptors on the inferior-posterior wall. From there, I draw a line going up to the brainstem. I label that line Unmyelinated C fibers, Afferent.
Keywords. Good.
In the brainstem, I draw a box and label it NTS and medulla. Then I draw 2 lines coming out. One goes back to the heart's SA node, and I label it vagus nerve bradycardia. The other line goes to the peripheral blood vessels, and I label it sympathetic withdrawal, vasodilation, hypotension.
And at the bottom?
At the bottom, I write the triad in big, bold letters. Hypotension, bradycardia, coronary dilation.
Perfect. A clear, simple diagram like that is worth 1,000 words of messy handwriting. So let's summarize this entire deep dive. Give you the final take-home exam points. This is the cheat sheet you read right before you walk into the exam hall.
Okay, the high-yield recap.
BJR definition is the triad. Hypotension plus bradycardia plus coronary dilation.
Receptors are in the left ventricle, specifically the inferior wall.
Afferent pathway is unmyelinated C fibers. Say it over and over.
Key triggers. Inferior wall MI, the interscalene block in the sitting position, and spinal anesthesia causing an empty heart.
Good, keep going.
5. The spinal mechanism is not just a sympathetic block, it's an active vagal reflex due to an empty ventricle.
Treatment. Fluids. First, preload is king. Then epinephrine as the drug of choice for collapse. Atropine for the vagal component.
OCR, triggered by traction on the medial rectus. Cranial nerve 5 inches, 10 out. First action is to tell the surgeon to stop.
Cushing's triad. High ICP leads to high BP and low heart rate. It's a sign of impending herniation.
Bainbridge is the opposite of BJR. High volume leads to tachycardia.
You're ready. That is a distinction-level performance. You didn't just memorize the names of the reflexes. You understood the logic of the sensors and the pathways.
Thank you, Professor. Honestly, it feels less like some terrifying magic now and more like plumbing and wiring.
That is precisely what anesthesia is. It's applied physiology in real time. These reflexes, you see, they aren't actually trying to kill the patient. They're trying to save them, just in a very primitive way. The BJR tries to save the heart muscle from ischemia. The Cushing reflex tries to save the brain from starvation.
But in the highly artificial environment of the operating room, those primitive survival attempts can be lethal.
Correct. Which brings us to our philosophical outro.
Right. We spend our entire careers fighting these reflexes. The BJR is nature's way of saying, the heart is tired and ischemic, let it rest. And we come in and say, absolutely not, you're going to pump harder, and here's a syringe full of adrenaline to make you do it.
It is a fundamental paradox of our specialty.
So the provocative question for you, the listener, to think about is this. If the Bezold-Jarisch reflex is an evolutionary masterpiece, perfected over millions of years to protect a dying heart, are we arrogant to so aggressively abolish it? Or is the operating room a unique place in the universe where the laws of nature and evolution are suspended by the tip of a needle?
That is a fine question for the coffee room after the case. But for the exam, treat the hypotension. Save the patient on the table.
Deal. Treat the patient first, pass the exam, and then debate the philosophy later.
Good luck to everyone sitting for the Gujarat University MD exams and any other anesthesia exam. Keep your heads cool and your atropine and epinephrine ready.
Thanks for listening to this deep dive. We'll see you next time.